Hi everyone, my name is Dr Rebecca Feo and I am a Senior Research Fellow within the College of Nursing and Health Sciences at Flinders University. Thank you very much for inviting me to speak at your conference today on nursing documentation. As you can see, I will be focusing on how it is that we might document and record the nurse-patient relationship. So my presentation today will take place in 4 different parts, focusing on the why, what, how and where. So in the why, we will look at why the relationship is so important and why we might measure it. In the what, we will look at what does the literature tell us about measuring the relationship. In the how, we will discuss some key issues around how the relationship should best be measured. And in the where, we discuss where do we go from here? What are the next steps? So after each section of the presentation, I will give you a series of questions as well to facilitate some group discussion. So, starting with the why. Why is the relationship so important and why might we measure and document it? So the nurse-patient relationship has long been a mainstay of nursing education, research, practice and policy. And we know from the nursing and healthcare literature that a trusting nurse-patient relationship has a positive impact on healthcare delivery and outcomes. So for patients, a trusting relationship can lead to positive care experiences and outcomes, including feeling safe and calm, trusting of the nurse, and also feeling like they're genuinely cared about. And of course, for nurses, building strong relationships with their patients can lead to feelings of satisfaction, because often they are providing the type of care that many nurses enter the profession wanting to provide. And perhaps most importantly, a trusting relationship is often what patients value most about their healthcare encounters. And so patients often view the relationship as a non-negotiable, and they won't readily excuse or accept when a nurse neglects to build that relationship with them. And this is perhaps unsurprising given the relationship is what patients feel and see and experience, and it's what they can readily articulate as well, both when it's good and of course when it's not so good. So nursing has historically had a very strong focus on the relationship, and the relationship has often been the hallmark of many seminal nursing theories. And in more recent years as well, the importance of the relationship has been reflected and reinforced by healthcare and nursing policies and standards, such as those focusing on person-centred care, safety and quality, and fundamental care as well. And these initiatives argue that a trusting professional-patient relationship is at the cornerstone of safe, quality healthcare. And indeed, the nurse-patient relationship is seen as the key mechanism through which fundamental care is delivered, as shown here in the Fundamentals of Care framework. So the idea here is that providing care for a person's fundamental needs can be challenging, both for the nurse and the person receiving care as well. Because fundamental care involves addressing intimate or personal needs, so needs that many of us engage in ourselves on a daily basis as part of routine self-care, so toileting, hygiene. But requiring help with those activities can become a source of embarrassment or frustration, and being able to skillfully negotiate the delivery of a person's fundamental needs requires that the nurse can connect meaningfully with the patient, can understand their unique care needs, and can treat them with compassion and respect. So in other words, it requires a trusting therapeutic relationship between the patient and the nurse. And as you can see here, the framework argues that this relationship can be developed by establishing trusts with patients, focusing on and anticipating their needs, getting to know patients and their unique care needs and concerns, and then striving to evaluate the quality of that relationship as well and making any changes as necessary and as they come up. And I also do have available on the ILC website a Danish translation of the framework as well if anyone is interested. So given our long-standing interest in the nurse-patient relationship, it might seem paradoxical that we are asking questions about how and whether we should document it. Surely if this is a concept that's so central to nursing, then we already have ways of assessing it, measuring it, and incorporating that assessment into nursing and patient records so that we can show the impact of the relationship on patient experiences and outcomes. But as I will demonstrate throughout this presentation, it's not quite that simple. So within clinical practice, there is substantial variability in terms of how nurses are able to establish relationships with their patients and how patients experience those relationships as well. And there's also substantial variability in terms of how the relationship is taught to nursing students, if it's taught at all, and how it's currently measured and how it's currently researched. And in recent years, there have been several landmark reports, which I'm sure many of you are familiar with, and these have exposed failures in care globally, and particularly failures in fundamental care as well. And they have further identified this variability and demonstrated that many patients are not receiving care predicated on a caring relationship with their nurse and of course with other health professionals as well. And the advent of COVID-19, of course, has brought these issues to light once more. So some of our colleagues in the UK, for instance, have shown that during the pandemic, nurses reported the greatest challenges around being able to provide relational care, more so than physical care. Almost half of the nurses who participated in this particular study stated that during the pandemic, it was more difficult to establish a relationship with patients who had COVID than with patients who did not have COVID. And that was primarily due to communication difficulties, not being able to spend as much time with patients, not being able to use facial expressions, non-verbal cues, and not being able to touch patients as well to demonstrate comfort and understanding. And of course, those difficulties were very much underpinned by the use of personal protective equipment, staff shortages, high patient acuity, and of course, many nurses being afraid of actually contracting the illness as well. But what those barriers meant is that many nurses focus primarily on functional physical aspects of care, while relationship building and the more psychosocial or emotional well-being side of patient care became a secondary priority. So what the literature often tells us is that it becomes a commonplace occurrence that when time is tight or when nurses must prioritise care activities, it's often the relationship that's missed. So it's clear that there is an issue to be fixed. But the question is, what do we do? And in response to these numerous care failures globally, there have been several calls from nursing, policy, and healthcare leaders to develop enhanced metrics for the nurse-patient relationship, in addition to other initiatives as well. The idea behind this is that what is recorded matters, and what matters is recorded. So in other words, if we want to see better relational care, if we want nurses to be able to build relationships with their patients, then one way to do that is by recording it and documenting it, because if it's recorded, it's more likely to happen. But importantly, this documentation, recording, this measurement is not purely an academic exercise. If we have robust and reliable measures on the nurse-patient relationship, that can provide really crucial information for nurses, healthcare leaders, educators, students and researchers on how it is that nurses actually develop and maintain relationships with patients in real time and the outcomes of that relationship development for nurses, patients, their families and carers, and of course healthcare systems. So measuring the relationship can provide evidence on the quality of nurse-patient relationships, ensuring patient safety and positive care experiences. It can also provide nurses with performance feedback information, offering resources for a reflective practice and professional development. It can inform organisational metrics as well, providing evidence for healthcare organisation to target areas for service improvement. And of course, it can inform nursing education and professional development, assisting educators in measuring, monitoring and evaluating students and nurses' progress in this area. But as I mentioned before, it's not that simple. So to understand whether we can currently assess and document the relationship, we first need to consider how this documentation might work within our current healthcare systems. So globally, most healthcare systems operate under managerial approaches, where the focus is on delivering care at a reduced cost and increased productivity and efficiency. So this means then that healthcare systems focus primarily on task completion and on measuring the performance of health professionals and the wider organisations in terms of very objective, codifiable activities. So a result of that then is that most nursing work is conceptualised solely as technical or physical tasks. And a lot of that is because those technical or physical tasks are seen as more objective and tangible, and therefore more easy to record and document. But of course, as I mentioned before, what we choose to measure and document in nursing and electronic records impacts what we value, what we prioritise, and how we deliver our care. So a focus on purely recording physical aspects of care, for instance, can often result in models of care that are depersonalised or mechanistic and transactional, at the expense of more relational models, where the focus is on engaging meaningfully with a patient in order to deliver personalised care. So for instance, bathing a patient under a managerial approach might be seen simply as an act to attain cleanliness for the patient. But under a relational model of care, it might be seen more as an opportunity to build a relationship with the person being cared for. So what we see then as a consequence of these types of managerial approaches is that some electronic nursing and patient records are built on body systems, where the aim is to identify discrete diagnostic and nursing interventions, but not necessarily demonstrating how those interventions come together to create an integrated care plan and a positive care experience for the patient. What we also see a lot within many healthcare systems globally is that metrics of patient outcomes often relate to risk, such as around risk of infection or risk of falls. And there are fewer metrics that focus on positive patient experiences. And of course, patient safety risks are important, but what it means is that psychosocial and relational outcomes and experiences are often overlooked. A recent study from Denmark, for instance, found that communication was not measured in any existing clinical quality databases. And if aspects of care relating to the relationship are measured, then it's often after the fact, so when they are incomplete or when an adverse event occurs. So in recent years, we have seen a proliferation of instruments that are designed to measure missed care or care that's left undone. And some of these do measure relational elements, albeit minimally. But what we have seen less of are attempts to measure the successful delivery of care or to integrate such care measures into patient and nursing records. And of course, these recording practices speak volumes. They demonstrate and reinforce the minimal value that is often placed on nursing and caring activities, and they render invisible to healthcare policy makers and managers and to nurses as well the role of the relationship and relational care in patient experiences and recovery. And the advent of technology might only make this worse. A recent paper, for instance, on the use of artificial intelligence in nurse-patient interaction argued that artificial intelligence can help reduce the time that nurses spend with their patients by, on average, 8 minutes, which again demonstrates the value or the lack of value that we place on the time that nurses spend with their spend with their patients, and time that could be spent building relationships. So what do we need to do? First of all, we need to move away from a system that is focused on recording deficits and towards one that is focused on reporting the positive contributions of the relationship and relational care, not only to patient experiences and outcomes, but also to those of nurses and wider healthcare organisations and systems. Because if healthcare organisations can't see that there is value from delivering relationship-centred care, and that can be value in terms of money or in terms of patient outcomes, then they won't invest the time and the energy in supporting nurses to deliver such care, and they won't spend the time embedding those metrics into electronic systems. And likewise, if relational aspects of care are not readily recorded, then there is little onus on nurses and little reward for them to actually provide that care to a consistently high standard. So a key question then is, do we have these metrics available to support this shift in focus and thinking, and which can be embedded into nursing documentation? And that is what I'm going to tackle in part 2 of the presentation. So before we get to that, I have posed the following questions for you to discuss. And I would suggest spending around 10 to 15 minutes having a go at discussing some of these questions. And then I will see you for part 2 of the presentation.